Welcome. In this session, we are going to look at the Popliteal Fossa, and by the end of this session, you should answer the following questions. What are the boundaries of the Popliteal Fossa? What are some of the contents of the Popliteal Fossa, and what are some clinical correlations related to the Popliteal Fossa? Welcome all. My name is Wallace Munyere, and I'm the URE Doctor. Now, let's start. Popliteal Fossa is a diamond-shaped hollow on the back of the knee joint, and which becomes prominent when the knee is flexed, but when it is extended, the hamstring tendons tend to lie against the femoral contents, and the fat of the popliteal space bulges to the roof of the fossa. If you palpate on the back side of your knee and you flex it, you will feel there is a hollow space, but when you extend the knee, the hollow space tends to disappear because the hamstring tendons lie against the femoral contents, and the fat in the popliteal space will bulge to the roof. Now, the fossa, why are we studying? Why are we studying this fossa? Because it is the passage of main vessels and nerves from the thigh to the leg. Vessels such as the femoral artery, femoral vein, and some nerves must pass through this popliteal fossa to pass from the thigh to the leg. Now, let's look at the boundaries. Now, this is a must know. Boundaries. Its superomedial boundary is formed by these two muscles, semitendinosus and semimembranosus. Its superolateral boundary is formed by the biceps femoris muscle. Its inferomedial border is formed by the medial head of gastrocnemius muscle. Inferolateral border is formed by the lateral head of gastrocnemius muscle, and you find some other texts adding that the inferolateral border is formed by the lateral head of gastrocnemius muscle in conjunction with the plantaris muscle. The reason why I have not included here plantaris is because not all individuals have the muscle. Instead, they have a popliteal fossa. The roof is formed by the strong popliteal fascia and the superficial fascia over the roof will contain the following structures. The short saphenous vein, which will pierce the roof to drain into the popliteal vein, and the three cutaneous nerves, the posterior femoral cutaneous nerve. We also have the posterior division of the medial cutaneous nerve of the thigh, and also the sural-communicating nerve, which is a branch from the common peroneal nerve. The floor is formed by the following structures from above downwards. So it is formed by the popliteal surface of femur. This is the most superior part of the floor. Then the capsule of the knee joint. Then the popliteal fascia over the popliteus muscle. So those are the boundaries. You find other text calling the roof the posterior wall and the floor the anterior wall. That is also acceptable. So here we are. This is the superomedial border, formed by the semitendinosus and semimembranosus, superolateral biceps femoris muscle, inferomedial, the medial head of gastrocnemius, and the inferolateral, we have the lateral head of gastrocnemius and plantaris. As you can see, here we are. You can see it is diamond shaped. This is the superior apex, inferior apex. These are the lateral angles. Now, here is the superomedial border, superolateral border, inferomedial border, inferolateral border. This is your, can see it has a long tendon, and this is your semitendinosus, a line on your semimembranosus. This is your medial head of gastrocnemius. This is your lateral head of gastrocnemius, and this is your biceps femoris muscle. Here you can see the sciatic nerve, which is bifurcating at the superior apex of the popliteal fossa into the tibial nerve and the common peroneal nerve. Now, How will you know this is lateral, this is medial? Maybe you can use the muscles where you see a muscle with a very long tendon that is semitendinosus, so that is medial. Also, you can use, you can see here, a nerve is accompanying the tendon of the muscle. Where you see a nerve accompanying a tendon of a muscle, that is the lateral, because this is a common peroneal nerve accompanying the tendon of biceps femoris muscle. Now, these are the structures which were in the roof. I'll save them. Now, what are the contents? It contains the popliteal artery and its branches, the popliteal vein, the tibial nerve, common peroneal nerve, popliteal lymph nodes, and the popliteal pad of fat. Now, let's look at each and every content. Popliteal artery. Now, popliteal artery is a continuation of the superficial femoral artery, which usually begins at the adductor hiatus. Now, the superficial femoral artery is a branch from the common femoral artery. Now, the superficial femoral artery usually runs through the adductor canal, and upon reaching the adductor hiatus, which is simply an opening in the adductor magnus muscle, it changes its name to popliteal artery. Now, it crosses the floor of the popliteal fossa from medial to lateral to reach the lower border of popliteus, where it terminates by dividing into the anterior and posterior tibial arteries. Now, the main branches in the popliteal fossa are the genicular arteries. Now, these genicular arteries are usually 5 in number: superior lateral genicular artery, superior medial genicular artery, inferior lateral genicular artery, inferior medial genicular artery, and the middle genicular artery. These first 4 form the superior lateral, superior medial, inferior lateral, inferior medial. They usually wind. They move from the posterior aspect of the knee to the anterior aspect, and they participate in the formation of the genicular anastomosis. But the middle genicular usually pierces the posterior aspect of the knee joint. It pierces the knee capsule posteriorly to supply the intracapsular structures. It supplies the structures which are found in the knee joint. Let's say like the knee menisci, the cruciate ligaments. Such structures are supplied by the middle genicular artery. Then the popliteal artery is susceptible to compression by the medial head of gastrocnemius. Now, when it is compressed, that is what is known as the popliteal artery entrapment syndrome. Now, and this happens when the artery takes a variant course where it deviates medially behind the muscle. So it will deviate medially behind the medial head of gastrocnemius, and then it will pass distally deep to the muscle. Now, as it passes deep to the muscle, it might be compressed, leading to the popliteal artery entrapment syndrome. Also, the artery may be compressed by an accessory slip of the medial head of gastrocnemius, which arises more laterally on femur, separating the artery and the vein or passing behind both. So that accessory slip might also compress the artery. Now let's look at that. Here is your femoral artery. Here somewhere here is where we have the adductor hiatus. It changes its name to popliteal. Is your femoral artery. After crossing the adductor hiatus, it changes its name to popliteal artery, and it gives off the following branches in the popliteal fossa: superior medial genicular artery, superior lateral genicular artery, or the lateral superior genicular artery, the way you might feel to name it. Then we have the medial inferior, or the inferior medial, and the inferior lateral genicular artery, and the middle genicular. You can see this one is piercing the knee capsule to supply the intracapsular. Then it will terminate by giving off the anterior tibial and the posterior tibial arteries. Now, popliteal vein. Now, popliteal vein is formed at the lower border of popliteus by the union of the vena comitante accompanying the anterior and posterior tibial arteries. Then it usually ascends superficial to the popliteal artery, and it will cross it from at the at the inferior aspect of the popliteal fossa, it usually lie medial to the artery. So it will cross the artery from medial to lateral. So at the superior aspect of popliteal fossa, it lies lateral to the artery. Now the popliteal vein continues as the femoral vein at the adductor hiatus. After crossing the adductor hiatus, it becomes now femoral vein. Now, popliteal vein lies at all levels. This is a very important point between the artery and the tibial nerve. So at all levels in the popliteal fossa, it will lie between the artery and the tibial nerve. It will receive tributaries that accompany the branches of the popliteal artery and the small saphenous vein. So its tributaries correspond to the branches of the popliteal artery. So branches such as the inferior medial, inferior lateral, superior medial, superior lateral, medial genicular veins will drain into the popliteal vein, and also the small saphenous vein, which will pierce the roof of the popliteal fossa to drain into it. The popliteal vein may take the form of a vena comitante on either side of the artery. So here we are. Let's look at the tibial nerve, then I show you an image. Now, tibial nerve is the larger terminal branch of the sciatic nerve. It usually extends downward from the superior angle to the inferior angle of the popliteal fossa. That is a very important point. Then it crosses the popliteal artery superficially from lateral to medial side, with the popliteal vein intervening between the artery and the nerve. It gives off muscular branches to gastrocnemius, soleus, plantaris, and popliteus. No, there is something important about the nerve to popliteus. The nerve to popliteus will also supply, I think, the tibialis posterior muscle, the superior and inferior tibiofibular joints, and the interosseous membrane. So, and these muscular branches, they all arise from the lateral side of the tibial nerve, except the nerve to the medial head of gastrocnemius, which will arise from the medial aspect of tibial nerve. So from that, you can see, since many muscular branches are arising from the lateral side is considered as the dangerous side of the nerve, where the medial side is considered as the safe side. In what aspect? Let's say you are carrying out an incision in that area. You don't want to tamper with the lateral side of tibial nerve because most muscular branches are arising from that aspect. But you can, on the medial side, it is relatively safer because only one branch to the medial head of gastrocnemius is arising from that side. But don't tamper with the lateral one. It will also give genicular branches which correspond to the superior, which include superior medial genicular nerve, inferior medial genicular nerve, and the middle genicular nerve, which will accompany the corresponding arteries. Its only cutaneous nerve is the sural nerve. Important point. Now, let's look at this relation. This is the inferior aspect, the superior. This is lateral, sorry, this is medial. As you can see, at the lower aspect, the nerve is the most medial, where the artery is the most lateral. But in the superior aspect, it is the other way. The artery is the most medial, and the nerve is the most lateral. As you can see, at all levels, the vein lies between the artery and the nerve, the tibial nerve. That is this relation is very important. So let's look at the common peroneal nerve. The common peroneal nerve is a smaller terminal branch of the sciatic nerve. It appears in the popliteal fossa beneath the long head of biceps femoris and slopes downward and laterally along the medial side of the tendon of biceps femoris up to the lateral angle of the fossa. Now, where it usually crosses superficial to plantaris, the lateral head of gastrocnemius, and to reach the back of the head of fibula. Then it winds around the posterolateral aspect of the neck of fibula. Now, as it winds there in living people like you and I, if you feel your lateral aspect of the leg and you feel the head of fibula, you can, at the neck below the head of fibula, you can roll, there is a cord-like structure there, which you can roll against the head of fibula. That is your common peroneal nerve. And after winding the posterolateral aspect of the neck of fibula, it appears the peroneus longus muscle. Peroneus longus muscle is also known as the fibularis longus muscle, and it terminates by dividing into two terminal branches, the superficial and deep peroneal nerves, or the superficial and deep fibular nerves. Now, genicular branches, the genicular branches of the common peroneal nerve include the superior lateral, inferior lateral, and the recurrent genicular nerves. Its cutaneous branches include the sural-communicating nerve, which usually join the sural nerve beneath the at the level beneath the muscular bellies of gastrocnemius, and also the lateral cutaneous nerve of calf. Those are the cutaneous branches of the common peroneal nerve. Now, let's look at the popliteal lymph nodes. Now, popliteal lymph nodes are few scattered nodes, some texts say 5 to 6, which usually lie at the termination of the small saphenous vein beneath the deep fascia. They usually receive afferent lymphatics draining a small area of the skin just above the heel, and a few on the lateral aspect, that is. These lymphatics, the afferent lymphatics, they run along with the small saphenous vein, and then they pierce the roof of the fossa and drain into the popliteal lymph nodes, and then lymphatics from the popliteal lymph nodes will run along with femoral popliteal and femoral vessels to drain into the deep inguinal lymph nodes, which are found in the femoral triangle. Now, let's look at that now in images, like these images. Now you can, as I had said earlier, these are the boundaries. I want you to identify them. Now you can see this nerve here. It is running from here, the superior, the apex, from this apex to this apex. That is your tibial nerve. Then you can see this must be your popliteal artery, number 14. Then in between them, here you can see the popliteal vein. Okay, and here you can see your common peroneal nerve. Okay, and then this is your medial sural nerve. Now the medial sural nerve is, see, I like calling it the sural nerve. Though some texts call it the medial sural nerve, and they call the sural communicating nerve as the lateral sural nerve, but I like calling it sural nerve to keep things easy. Then here you can see in these second images, you can see the branches. This must be your superior medial genicular artery, superior lateral genicular artery, which is this one. This must be these are sural arteries and the veins. You can pause this video if you want to see it now, but I have this. This is the plantaris muscle. Plantaris muscle, other people call it, in quotes, freshman nerve. Why? Because it has a very long tendon. It will go to insert on the posterior aspect of the calcaneus, your heel bone, via the Achilles tendon. So it has a very long tendon. That tendon, most freshmen, the first years, they confuse that tendon to a nerve. That is why it is called a freshman nerve, but it is a muscle. Plantaris, it is not found in all people. It is a rudimentary muscle found in a given population. You can see this is a tibial nerve. Maybe you can pause the video to see that. Now, what are some clinical correlations? Now, popliteal pulse. To feel the popliteal pulse, the patient has first to flex the knee, then so as to relax the popliteal fascia. Then you place the fingertips of both hands in the popliteal fossa with the thumb resting on the patient's patella. Patella is your kneecap, that bone. Then the popliteal pulse, then you will feel the pulsation, but popliteal pulse is the most difficult pulse to feel amongst all peripheral pulses. So you better use other pulses such as the radial pulse, the Salisbury's pulse. We will look at them. Then we have also popliteal aneurysm. Now, popliteal artery is more prone to aneurysm than any other artery in the body. How does this aneurysm present clinically? It will present as a pulsatile midline swelling in the popliteal fossa. So if a patient comes and has a swelling in the posterior aspect of the knee, and it is pulsating, its pulse are corresponding to the radial pulse, that is a popliteal aneurysm. Then you have another condition known as the Baker cyst, which is a cystic swelling which occurs in the popliteal fossa due to inflammation of the bursa. A bursa is the fluid-filled cavity which is responsible for lubrication. Now, if you have inflammation of the synovial bursa underneath the tendon of semimembranosus, or you may also have protrusion of the synovial membrane of the knee joint cavity through the fibrous capsule of the knee joint, will lead to a cystic swelling, which is known as the Baker cyst. So this swelling will be non-pulsatile. It will not, it would have a pulse like this. This will have a pulse, this won't. So thank you guys for your attention, and subscribe for more anatomy and biochemistry content.